Good evening, delegates. Thank you for joining Shield Connect. So today we have Dr. Divya Ji from Salem, and today she's going to speak on menopause management. So before we start with the session, let me give a little introduction of our page Shield Connect. So let me share my screen. So this is our page shieldconnect.in, where you can find the different sections are available: blogs, webinars, awareness pages, leader section, and specialty pages. So if you click on blogs, you will find all the blogs which are being written by our eminent speakers who are connected with Shield Connect. Then we have a webinar page where you can find upcoming webinars as well as past webinars. So if you click on see more, you will able to join our today's session. And when you click on past webinar, you will find all the webinars that have been conducted till now on Shield Connect page. Then we have the awareness pages. So if you click on any one of the topic awareness page, like if you click on PCOS awareness page, you will find all the different videos regarding PCOS and in different languages by different doctors, like in Hindi, Tamil, Malayalam, English. Okay, so this is our page, and there is our leader section where you can find all the speakers who are connected with our page. So you can also go through their profile in detail. So this is our page Shield Connect, and now let me give a brief introduction for our speaker for the day, Dr. Divya Ji. So, ma'am has done a DGO, DNB, MRCOG, MNAMS, FMAS, DMS, and SIMS, and diploma in Uro Gynecology and Pelvic Floor Reconstruction Consultant. And ma'am is consultant, obstetrician, and gynecologist in Wims Hospital and Max Specialty Clinics in Salem. Ma'am has done MBBS from Thanjavur Medical College, DGO from Stanley Medical College, DNB from CSI Kalyani Hospital, Chennai, MRCOG, Royal College of Obstetrician and Gynecologist from UK, and diploma in Minimal Asset Surgery, World Laparoscopic Hospital, New Delhi, and credential to IMS Menopause Practitioner. And the special interests of ma'am is menopause, urogynec, and high-risk obstetrics. So ma'am has have vast experience in this field. So I welcome you, ma'am, on our platform for today's session, and I will hand over the session to you, ma'am. Thanks to join with us on Shield Connect, ma'am.
Thank you. Thank you for the kind introduction.
So Raj, please
start sharing the screen. Okay. So my topic for the day is menopause management. So menopause management. So menopause is like very before going to the topic proper, I just want to say what is the importance of this menopause. Menopause is like very important topic which is neglected in the developing countries, and many women suffer in silence in this menopause. And we have remedies for that, and we have like counseling and proper counseling for that. Which can help the woman who is suffering there in silence. So it's very important to know about the menopause and menopause management. So what I'm going to do is, today I'm not going to discuss more about what is menopause and what all it will do. I'll just focus on like what other things can be done, like what lifestyle changes can be done, how it can be done in the exercise, in the diet, and then all other non-pharmacological things, and then about the pharmacological things, about the myths related to menopause. So going to the topic proper. Next slide. So what is menopause? Menopause, we always describe that with the terminology called terminology final menstrual period. It is the 1 year of no menstrual bleeding. That is called as the final menstrual bleeding. That year is considered as menopause. After 1 year, we clinically diagnose the patient as menopause patient. It represents the permanent cessation of menses, which means there is no ovarian function after that. That is actually a normal thing due to aging. Next slide. So menopause should actually occur naturally. The average age is like 51, but due to certain circumstances, patient will undergo hysterectomy with bilateral oophorectomy or any chemotherapy or any other reason, or like patient may have premature ovarian failure insufficiency, which can occur early menopause before 40 years. So menopause can happen naturally, or it can be surgical menopause, or it can be premature ovarian failure. Next slide. Okay, so this slide shows us the importance of menopause. In the Indian population, like 48% of Indian population are women. Among that, 11% of women are around 40 to 60 years. So majority of population of women are in the age of 40 to 60, where they suffer a lot. So we need to focus a lot on that age group, and we have to know what is exactly happening in them. Next slide. Okay, so this is what I said, which is called final menstrual period, and we separate the stages like reproductive, menopause, transition, and post-menopause. So the amenorrhea of 12 months indicates that that period we can diagnose. After that we can diagnose menopause. So the transition happens very slowly, and usually it takes like 8 to 9 years before the menopause. So in the reproductive age group, it will be normal FSH will be there, and then slowly the FSH level will increase, and then going on later the FSH will increase and AMH will come down, and in the menopause the FSH will increase and AMH will come down. So this is actually a transition period where the symptoms, everything start in the transition period. It's not after menopause, it actually starts 7 to 8 years before the menopause. Next. Okay, why this has come to many more importance, like the age of menopause has remained constant, and because of our lifestyle changes, the age has also reduced in our country, but the life expectancy has increased. The age of menopause remained constant, but the life expectancy has increased. So the people living after the particular age is increased. So we need to definitely we have to look into all the symptoms so that we have a goal like independent at 80. So we can't go and do things at 60 to be independent at 80. So we have to start everything in advance so that we can make the woman to be independent at 80. Next slide. Okay, so what happens at menopause, like the serum hormone levels, everything comes down. So that is the main culprit. The estrogen, which will be there in a proper adequate amount, will actually come down. There will be a ratio change in estrogen to androgen. The sex hormone binding globulin secretion will reduce, and there will be increased peripheral aromatization. And there will be reversal of the ratio estradiol to estrone. And there will be no significant changes in the testosterone level. Next. Okay, so this slide is very important because this says like where all the estrogen receptors are situated, and it also says that if estrogen depletion happens, it says like what all complaints will come during menopause. So actually the single slide describes everything about menopause. So first thing is brain. So that is the reason when the estrogen reduces, hot flushes come, irritability, mood disturbance, there will be dementia, insomnia. So everything which occurs due to depletion of estrogen in the brain. Next, breast, and then eye they have macular degeneration, and then genitourinary tract. We all well know that there is atrophy and urinary incontinence and dyspareunia after menopause. And heart and blood vessels, women are more prone for cardiovascular disease. The risk actually increases after menopause because of the presence of receptors there. And the next is the liver, where there is an adverse changes in lipid profile, which is an indirect marker for the heart problem. And then ovarian, fertility depletion, follicle depletion, and fertility reduces. Skeleton, it is very well known that osteoporosis occurs. And skin and hair, we know skin and hair thinning and everything happens after menopause. So these are the main areas where estrogen receptors are located. Next. So we know like estrogen alpha and estrogen beta receptors. Next. So this is the thing, like when it starts reducing, when the estrogen level in a body starts to come down, we have short-term symptoms. Next, the symptoms actually starts with the hot flushes, mood and sleep disturbances, and then it continues with the urogenital symptom. Usually the urogenital symptom and skin changes, everything occurs like 3 to 4 years after the occurrence of menopause. The same like cardiovascular disease, it also occurs 4-5 years after that. But the late onset will be like Alzheimer's and cognitive decline. Next. So we know vasomotor symptoms. It is one of the worst symptoms which a woman can experience in that time, because in that age they will be like very challenging. They may be having a challenging work if they are at home or even at outside when they are working. So the peak age of their time where they have to concentrate a lot and where they will have a more responsibility in their life. And this thing affects most of the women. If it comes, they can't do a high challenging work, or they can't take even a little stress. It is very like worsening, and many women suffer actually. They usually say that there is a sudden wave of heat inside the body, that too in the upper body, and they suffer a lot. And many land up with the psychiatry department and cardiology department for that reason. Next. Next. Next slide.
Raj.
Okay, this is how hot flushes comes. It's the increase in core temperature and increased sweating happens in the upper body. Next. Okay, vaginal symptoms, it's like because of the loss of estrogen in the estrogen receptors, vaginal dryness, thinning, everything happens, and that leads to irritation, itching, and dyspareunia. And like vasomotor symptoms, it comes immediately, but vaginal atrophy, it's like it takes at least 1 or 2 years. After that only it comes. And treatment for that is regular sexual activity, lubricants, and moisturizers. And in some cases, they can go for local vaginal estrogen after ruling out all other causes. Next. Okay, this is how the vaginal atrophy happens. Next. Okay, sexual issue is a very big problem at that age, and many do not open up. The main concept in the management of menopause is like yeah, every time I'll be telling that, but again and again I used to say it is an art of counseling, which is given in a guidelines. Art of counseling. The more you talk, the more the patient will open up. The main thing in the menopause is it shouldn't be coupled with the normal OP. We have to give particular timing and we have to spend a lot. Only then the woman will open up and discuss all the problems and the woman will benefit. So definitely they'll have sexual issues, and most of the women in our country, they don't open up. And for that, we can explain them lubrication, and then if needed, we can start HRT also. Next. Okay, now we are coming to the lifestyle changes. So main importance in menopause is if we give a proper advice at the proper age, that is before like if it is like a screening, we screen all the women above 35, and if we give a proper advice to the women who are at help, it will be of great help and woman will not suffer. So the main thing among that is what she has to do is she has to eat right, she has to exercise properly, and the proper medications. Next. Okay, so what is therapeutic lifestyle? We can say I'm having a healthy lifestyle, but what is therapeutic lifestyle? Therapeutic lifestyle is an physical activity, which is a targeted exercise. We should plan the activity and do the activity. Nutrition, should avoid alcohol and tobacco. Stress reducing strategy, because I say to all my patients, if something is giving you stress, just avoid that, because if many of the stress we know, like if we are starting the discussion about that topic, and if it is going to end up with the stress of fight, it is better to avoid that topic. So in that age, it is very, very important, which will not like stimulate a hot flush or stimulate a vasomotor symptoms. Okay, so all the stress reducing strategies, which can be done by meditation or respiratory exercises, but I usually say it that way. And then massage, hobbies, emotional stability, having a positive attitude towards the aging. That is very, very important. All women should have a positive attitude. They should not think that their life is at the end of menopause and everything is an end to that. Okay, and then family involvement, spiritual attitude, and sleep. Next. Okay, so physical fitness. Physical fitness is nothing but a very slow walking or something like that. We all know the most common fracture, which is trivial fractures due to osteoporosis, happens in the upper limbs. So it is very important. They should have a weight bearing exercise for the upper limb also, both for all the bones. Weight bearing is very, very important. Resistant exercise at least 2 days per week, and the remaining 5 days aerobic exercise is very, very important. And beyond that, flexibility reduces with age. So flexible exercise and balance exercise are also very, very important. They should not say like I'm going for walking and still I'm suffering from all those things. It should be balanced exercise with aerobics, weight bearing, flexibility, and balance exercise. Next. Okay, so we all know the benefits of exercise, but just to summarize for the menopause patients, it helps to maintain a healthy weight, it increases the BMR, it improves the bone density, it is very, very helpful in coordination balance. Balance is very, very important in old age, because they lead to, if the balance is not there, they have falls, and falls leads to fractures. So coordination balance is very, very important. That is increased by exercise. Muscle strengthening and joint mobility, and we have lipid profiles increased, we have evidence, and that leads to reduced cardiovascular risk. Improves genitourinary symptoms, release depression. We all know we get happy hormones when you do exercise, and also induces sleep and increases the quality of life. Next. Okay, so what is physical activity? What is exercise? When we explain our patients, they say like my work daily is like a very severe physical work, and I'm doing a lot. I'm walking a lot. Do you want me to do exercise apart from that? Yeah, it is very important. They have to do a continuous sustained exercise. So physical activity is like any body movement which can be done by any muscles. Exercise is an activity which is planned, structured, and repetitive, and purposeful to improve or maintain some component of a fitness or health. So it is very important. We can't couple that with a work. We can couple that with work, like increasing body movements can be done with a normal work, but exercise cannot be coupled with a normal day-to-day work. So both are very important for health. So counseling is very important. As I said, it increases activity, and more important is they should be thought about Kegel's exercise. When the hormone falls, definitely the pelvic floor also relaxes, and it leads to all problems, prolapse and urinary symptoms. So Kegel's exercise is a must for all menopausal women, which they should do to prevent all other thing, and it also increases the blood circulation. Next. So here are the recommendations. What are the recommendations? How much do we tell them? What all we should tell them? So we should say that it should be a mixture of aerobic, muscle strengthening, breathing, and balance. But if they want to just maintain their weight, we can say them, we have to do 30 minutes of moderate to intensity physical activity. So how to measure this moderate to intense physical activity? If they both are able to talk, have a conversation comfortably, it is called a mild activity. They're not able to have a conversation comfortably, it is a moderate to intense activity. They shouldn't be able to make a perfect conversation. That says that it's a moderate to intense physical activity. It should be moderately mostly 5 days in a week. Muscle strengthening should be 2 days per week. For fitness and reduced risk of chronic disease, there should be a minimum of 30 minutes activity. To prevent weight gain, it should be a 60 minutes activity. To avoid regain of weight loss, they have reduced weight, but to avoid regain, they should at least do 90 minutes. That is 1.5 hours per day to avoid the recurrence. Next. So nutrition is very important. We all know that. Next. Okay, the recommendations in nutrition will be sugar should be 6 tablespoons per day, and salt is only 1.5 tablespoon, oil only 2 tablespoon. Otherwise, oil can be also measured in terms like if a 2 persons are there at home, they have to use only 1 liter of oil per day. That is half a liter for a person for a month. Okay, and then fruits also contains natural sugars. That is also not recommended in high quantities. It is only 100 grams per day. Vegetables 300 grams per day, and 8 glasses of water is very important. And for the woman around menopause, natural products like which can help them vasomotor symptoms is flaxseed, cinnamon, fenugreek, which can be added in salads and curds. And they can take nuts like almonds, walnuts, dates, fig, and all. They can take in
Dear delegates, please wait for a few moments. There must be some technical issue from our speaker. Please wait for a few minutes. I will update you.
Am I audible now? Am
Yeah,
I
yes,
audible?
madam.
Yes, ma'am. Yes, ma'am.
Sorry for the interruption. We'll proceed. Okay, next slide.
Yes, ma'am. No.
Next. Okay, this is very, very important because in our country, it is we are more addicted to tea, coffee, and dairy products, and it is very, very important because we never know that more intake of tea and coffee will cause hot flushes and vasomotor symptoms, and it also has an impact in the bone health also. So it should be considered that not more than 200 milligram per day of caffeine, which is like less than 3 cups per day. One cup of like 150 ml of brewed coffee is equal to 120 milligram. So it means that if you're taking 2 cup of coffee, it exceeds actually the recommended amount. So 65 milligram for 1 cup of instant coffee and tea. So consume a minimum of at least minimum 500 to 600 ml of milk or curd, which will actually increase the calcium bank. And it should be added with the vitamin C and other fruits and vegetables. Next. Okay, this is very, very important because we hear a lot from a patient saying that they have a sleep disturbance during menopause. That is mainly because of hot flushes or irritability or due to any other reason. But they should all have a sleep hygiene so that they don't suffer a lot. Going to bed at the same time is very, very important. It should be a dark, quiet room, like comfortable temperature should be there because they require more less temperature than the others. Because since they are more prone for hot flushes, they usually require a temperature less than the others. They should avoid a large meal, exercise, caffeine, nicotine, and liquid 2 hours before sleep. It should be a dim light bedroom environment with no gadgets around. Minimum like a gadget should be used 1 or 2 hours before going to sleep. Next. Okay, this is more important, keeping our mind young. In the menopause, they are more prone for dementia, and that is the main reason we'll come to know that they are in the old age and they suffer a lot and they will not have acceptance for that. So it is always very, very important to learn new things and we should tell them to pursue a new hobby, to continue working. If some say that I'm already 50 or 55, I'm planning to take a retirement, it is better to tell them to continue their work if it is not affecting them a lot, to continue work so that the brain will be active, and they should read a lot. And the evidence is Sudoku reduces the dementia, so which can be encouraged in menopause patients. Next. And spirituality, diverting the mind of menopause patient to prayer, meditation, having positive attitude will also help them a lot. Next. And emotional well-being, like emotional well-being, they should have each and every chance to bond with the family and friends. In fact, if they are like apart from this pandemic situation, if they want to participate in social activity, we should tell them to take part in all social activities, so that will increase their memory power, talking about old things and everything. And they should enjoy conversation and be happy and contented about their life. So now coming with the nutrition part, the calcium recommended is, we all know, 1,200 milligram per day, and vitamin D is 1,500 to 2,000 international unit per day. Next. 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 Okay, so these are the different type of calcium supplements. When we give calcium supplements to the woman in the old age, we always have a worry about uh, like we are always worried about calculate. So that is actually avoided when we choose a salt, better salt, like calcium citrate is chosen. The more chances of renal calculate, we can reduce the chances of renal calculate. Next. Next. Okay. So if we are giving supplements, the calcium in the food, we have to assess the patient, like how much they're taking, how much calcium they're taking in their food. If you're giving supplements, we have to say that we have to adjust in such a way that if they're taking milk or curd in the morning, we have to give the supplements in the night. It should be adjust the timing according to the patient. We have to talk a lot with the patient to know about their routine. Next. Next. Vitamin D is very, very important, which I said, which should be given in 2,000 international units per day. Next. Otherwise, we can we can tell them to have a exposure, have a sun bath, like between 11 to 3 a.m. for 20 minutes. Next. So that which 11 to 2 p.m. is the preferably best. So they should have a proper exposure. They shouldn't be covered with clothes, no sunscreen. It's not a window glass. And okay, next. They can get vitamin D from sunlight source between this time. Next. Next. This is what I said already. Okay, so this is the vitamin D recommendations. We have to give 16,000 international unit once a week for 8 weeks. And then after that, it is actually, if it is a winter, we have to give monthly twice, or if it is a summer, we have to give monthly once throughout their life. Okay, after ruling out all the contraindications. Next. So once in a month in summer and twice in a month in winter. Next. So now coming to the hormonal therapy, we know we have more controversies in hormonal therapy. So hormone replacement therapy, which is very needed in premature menopause, because we have to provide the adequate amount of hormones for them till the natural age of menopause. So that is very needed there. Apart from them, the other treatment is estrogen therapy, where there is no intact uterus, and estrogen progesterone therapy, where uterus is there, and androgen therapy in few cases. Next. So we have a wide range: natural estrogen, progesterone, androgen, tibolone. Next. Okay. In natural, we have 17 beta estradiol, estrone, estriol, conjugated equine estrogen. Next. 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 Okay, so this is the concept right now. We can use hormones, but we have to assess the patient carefully for the side effects and all. But always use the lowest dose of the hormones, and then we can always call back the patient and see whether the symptoms improve or not. And the meanwhile, we can also see whether the patient is developing any side effects, whether we need to adjust the dose. It is always patient based only. There is no fixed regimen for the patients. We have to talk with the patient according to her symptoms. What we have to customize for the patient. So there is a variable response for an individual to estrogen deficiency. So there is no single regimen. Like, we have to suit the woman. We have to talk with the patient. We have to give the regimen. Okay. So one type of hormonal therapy cannot fit all population of postmenopausal women. Benefits of hormonal therapy can be maintained with lower doses than previously used, while minimizing the risk and possibly side effects. So improved continuous and compliance to achieve potential long-term health benefits, because it also helps them to continue, because the side effects will be very less. And efficacy in prevention of osteoporosis is not compromised. Next. Only in these three conditions we cannot give low dose therapy, where, like, premature ovarian failure, as I said, till the age of natural menopause, they have to receive the high dose of estrogens. And then in severe osteoporosis, and also like depression and all psychological problems, we have to give high dose therapy. Next. Okay, non-oral routes, we take non-oral routes because we all know when the patient has side effects like migraine or diabetes, we don't prefer oral route, we prefer the transdermal route. So that is the first line there, where the lipid profile is altered and patient have migraine. Next. Okay, these are the indications where obesity, smoking, and previous VT, varicose veins, and all. If the patient has a personal preference, we go for non-oral routes. Next. Next. Okay, so this LNG-IUS, like, it can be given in the HRT, it can be given for the progesterone part, where all it can come into actions like during perimenopausal period, when the patient is having abnormal uterine bleeding, we can use this. And it can be also given as a contraception way, which is a very big fear in the menopausal age, because many women land up in that age thinking that the irregular periods is because of pregnancy. So it can be given, and we can say that it serves also the purpose of contraception and also for the control of bleeding. And the woman with side effects for oral progesterone, the next alternative non-oral will be levonorgestrel system. Next. Okay, next, to overcome the side effects of progesterone, we say micronized progesterones can be used instead of normal progesterones. Okay, next, because it has no neutral effect on breast. And androgenic progesterones have the high risk profile, so we know that. Next. Okay, progesterones after surgical menopause. So we know that progesterones is not needed after the surgical menopause when the uterus is removed. But in certain cases where there is an endometriosis or frozen pelvis, where a residual ovarian tissue is also there, in those conditions they will have a chronic pelvic pain which will not respond to estrogen, or where we have to give only progesterone. Okay, next. So concepts in prescribing hormone replacement therapy, it's like we know there are different routes and there are different effects, and we also have different risk and benefits for different age groups. Next, so it is always individualization. So we should rule out the contraindications. We should give adequate counseling, and then before starting that, we should give adequate counseling. And timing window, it's like we can't start an HRT like after 5 years once the skin is thinned and vaginal atrophy has come and all the changes of menopause system. It is always very, very important to assess the patient and start at the earliest. It is a window of opportunity. So we use that opportunity to treat the patient so that we avoid chronic diseases like diabetes, hypertension, and cardiovascular disease. There is no point once the patient develops all other things. So it is very, very important to have an early start and assess the patient, and maintenance of estrogenic benefits. Next. So patient selection is also very, very important. There is no generalized prescription for menopausal patients. It is tailoring dose to the patient, and it is always like continuation and tapering the dose with age. Next. So concepts, as I already said, there is no mandatory time limit, but usually they say it can be continued till 10 years from menopause, not to be continued after 60 years, only if it is indicated. And as I already said, it is always the minimum effective dose which should be used. Follow-up should be annually. Next. So we all know evidence, what all evidences we have, like we have the three main beneficial effects of estrogen. It relieves the symptoms, it has a very big relief in the urogenital atrophy, and it also helps in the osteoporosis. So most effective treatment for vasomotor symptoms is hormonal treatment. It is one of the best effective treatment. Even we can try everything, but the best thing will be the hormonal treatment for vasomotor symptoms. Progesterones and low dose contraceptive pills can be used in the menopause transition period for relief of symptoms. The low dose OCPs can be used for the relief of symptoms. So vaginal estrogen therapy is the effective for urogenital atrophy. Next. And chronic therapy for atrophic vaginitis, it is actually the smallest effective dose which is used, and it also prevents, it can be also used in rectal uteri, which should be done after ruling out all other causes of bladder causes. Next. And we know it is useful for the prevention and treatment of osteoporosis, reduces the risk of spine, hip, and other fractures. And it should be used for bone pressure within 10 years of menopause. There is no use in giving hormones after 10 years after menopause, and it will not help anything for the movement. Next. Yeah, it improves the quality of life. How it improves the quality of life? It enhances the mood with because mood disturbance is there, mood, irritability, everything it improves, so that it helps in the quality of life. Next. Okay, the other benefits like indirect benefits, it reduces the risk of type 2 diabetes. This is all the evidence based. It reduces the risk of type 2 diabetes. It reduces the abdominal obesity. We all know like after menopause, they usually have an abdominal type of obesity. So that is actually reduced. And it also has a protective effect on osteoarthritis. And it benefits the verbal memory over the short period after surgical menopause. And it reduces the neovascular macular lesions in the eye. Next. So before prescription of any hormones, we should always have an adequate counseling and then documentation of all those things. We should have a proper history taking and to rule out other medical conditions, and all the investigations, basic investigations should be done. Like dose, duration, follow up, when they should come, why it is given, what is the reason for writing, that should be documented clearly and explained also clearly to the patient. So if everything is okay, there are no contraindication, it is always better to offer hormonal therapy. Next. Next. So this next. This says that the risk associated with the usage of hormonal therapy and placebo. The placebo, when we take all these things, the comparison says that it's very, very less when it is used. Like the side effects are actually very, very less when the low dose is properly used for the proper selected patients. Next. 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 Okay, regarding hormonal therapy and breast cancer, there is a lack of safety data which supports that, which can be used in breast cancer survivor or all those things. It should be tailor-made after having a multidisciplinary team discussion with the patient and also the other doctors. Next. Okay, so this is like cardiovascular risk within 10 years of menopause. If the hormonal therapy is used, it actually reduces the cardiovascular risk for the patient. And in the regarding the breast, it does not actually increases the risk for breast cancer. Next. Okay, venous thromboembolism is also not increased without, if there is no other history in the family, it does not increases. Next. Okay, we all know well known that it is actually used for the thing, but it shouldn't be used as a primary thing for the osteoporosis. Next. Next. Okay. Next. Next. Okay. So, okay. Previous slide. So this is how we go with the patient. We should assess the patient. So we should also ask whether the patient is interested for taking menopausal hormonal therapy. And the age should be, as I already said, it should be less than 60 years. There is no point in starting hormones after 60 years, at least less than 10 years since menopause. So if her age is more than 60 or more than 10 years since menopause, we should consider the other options available. Apart from the hormonal therapy, we have other non-hormonal therapy for the patient. We can go for that. If okay, if the criteria is fitting in, we should also consider the other circumstances, and it should be avoided in patients with unexplained vaginal bleeding, stroke, breast or endometrial cancer, active liver disease. If all these things are present, we should consider other options. Next. Next slide. Okay, so caution should be there in diabetes, hypertriglyceridemia, active gallbladder disease, and the increased risk. If the patients have increased risk for breast cancer and migraine, we should always have a caution. If everything is absent, we should evaluate the cardiovascular risk. If it is high, it is always better. Once it is already set, there is no point in giving that. And then if it is acceptable, we should also evaluate the breast cancer risk. If it is also acceptable, we have to go next. If it is acceptable, we have to see whether the uterus is present or not. And then if the uterus is present, we have to give estrogen with progesterone, or tibulin can be considered. If no, we have to give estrogen alone. Next. Surgical, so patient characteristics that may be favorable for estrogen androgen combination, like surgical menopause. Next. Next. Okay, so when we're starting hormonal therapy, we should explain the woman, and we should tell them to review, like they have to come after 1 month and then 3-month review appointment, and any unscheduled vaginal bleeding, which is a very common side of HRT, within the first 3 months of treatment. So we should reassure them, and if it is like, if they are not comfortable with that, they have to come. And it will take 3 to 4 weeks for the control of symptoms. The symptoms will come only after a month. They will have a control of symptoms, and we also have to reassure them so that they will wait patiently. Next. Next. We all know the routes of administration of oral transdermal. So this is how the next. This is how it is given. Continuous sequential can be given, like estrogen is given throughout the cycle, and then at the end we can give progesterone for the last 14 days, or you can give a continuous combined with it, which is like estrogen and progesterone, like a low dose OCPs. Or if there is no uterus, we can give a continuous estrogen without a break, and no, they will not have a bleeding. Without a break, we can give. Okay, next. 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 This is all the regimens what I already said. Next. So problems from HT already I said, like they can have a bleeding problems, and they can have insufficient symptomatic response. They may not respond to the symptoms, will not come down, and they can have side effects of the hormonal therapy, which should be addressed then and there. Next. Next. So the problem, like bleeding will be a very big problem as a complaints part. They can have a like with the sequential pill, they will not have much bleeding, but the unscheduled or irregular bleeding will have a very big problem with the complaints. Next. 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 The other causes of abnormal bleeding should also be taken as differential diagnosis when the patient says that if they develop a bleeding in between, the other differential diagnosis should always be considered, like endometrial hyperplasia, cervical erosion, cervical polyp, atopic vaginitis also should be considered before stopping the medications. Okay, next. So when to investigate? Routine endometrial surveillance is not needed in patients like when they're taking hormonal therapy. So with cycle irregular bleeding starts at the end of at the start of progesterone therapy, or these changes in the duration or intensity of blood flow, which is normal for that woman with continuous combined regimens. If bleeding is heavy or continuous and continues after 6 to 12 months of use in women with the high risk for uterine cancer. Next. We know like insufficient response with the poor compliance and poor absorption. Next. 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 These are like fluid retention, bloating, breast tenderness, headache. Next. Mood changes, nausea will be there always. These are the side effects. So contraindication for hormonal therapy. This is very, very important. We all know like active endometrial gynecological hormone dependent cancers we should not start. Active breast cancer, estrogen progesterone receptor positive cancers, or suspected pregnancy, undiagnosed abnormal vaginal bleeding, severe active liver disease with impaired or abnormal liver function, previous personal or family history of venous thromboembolism, SLE. Next. Next. Migraine headaches. This should be used with caution. Migraine headaches. Okay, so stop treatment if migraine appears for the first time, or if headache gets worsened, there is a blurring of vision or any symptoms suggesting of vascular occlusion, or if jaundice appears, if there is a significant rise in blood pressure, and HT to be stopped 4 to 6 weeks before elective surgery. This depends upon the surgery, and it should be like stopped only after having a discussion with the primary treating physician and also the gynecologist. Next. Next. So, okay, these are the conditions where it is not contraindicated. Next. Depression. Next. So, okay, after 1 month of 1 month, patient should be checked. Previous slide. Okay, so after 1 month, patient should be checked for efficacy and side effects, and then we have to check weight and blood pressure at every visit, and after 3 months to assess the effect and compliance. Next. And then patient should be followed like annually. Annual checkup for all menopause patients is very, very important. This is even if they don't have a hormonal treatment, it is always better in menopause to assess the symptoms and treat accordingly in menopause patient annually. So we have to check for the efficacy if hormonal treatment is used. We can see for side effects, complaints, weight and BP should be checked. There should be a thorough physical examination, including the genitals, and then the breast, and update of medical and family history, any new history in the family, and relevant laboratory and imaging investigations. We all know PAP has to be continued till 65 age, and mammogram has to be taken. So everything we do annually according to the patient's risk, and we should also have a discussion about how their lifestyle changes is going on and how they are able to adhere to that. And as I said, pelvic pathology should be always ruled out in the routine checkup, and breast cancer screening with the appropriate self breast examination or mammogram should be explained. Next. Next. Okay, this is as I already said, like up to the natural age of menopause, we have to continue hormonal treatment for premature menopause. Next. Next. The duration of therapy is like they don't have an exact cutoff. We can continue like how much time we can do, but it is always better to stop at the age of 60 years. Next. So these are the follow-up investigations. As I already said, blood, urine examination, blood sugar and lipid profile, pelvic ultrasound, mammography, pap smear every 3 years, and DEXA once in 2 to 5 years. Next. 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 So this is all about Tibolone. Next. So which is a very, very important thing is it's not recommended within 1 year of menopause. Next. 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 Okay, genitourinary syndrome, which I've already informed, it is very, very important. So we can give them the local estrogen cream if they have a vaginal symptoms like burning sensation, itching sensation, or when they have dyspareunia, when they have a recurrent urinary tract infection, they have an overactive bladder after ruling out all other causes. And in the case of vaginal surgery, we can give pre and post operatively. And pap smear, if this pap smear, the cervical zone is not seen properly, we can give them. So here and all, we can use the vaginal estrogen therapy. Okay. Next. Next. So we know there is no systemic side effects with vaginal preparation. These are the vaginal preparations available in India, like Primarin, Evolon, Learn tablets. Okay. Next. 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 I skip all these things for time being. Next. 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 This is all like for osteoporosis treatment. Next. 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 Okay. So like if the patient is having symptoms, we give them, this is regarding the therapy which we totally give. The patient is having symptom relief within 6 to 8 weeks. Okay, we will have a proper follow-up of the patient. If the patient is not having symptom relief, we have to change the dose or the route of treatment, and then we'll review 6 to 12 months review, where we'll see whether there is a recurrence of symptoms, and then we will have a specialist review if needed, or else we review them with for side effects and the risk associated. Next. Yeah, this is like any menopausal woman after 5 years of age, DEXA is very, very important. Less than 5 years, if they have a risk factors, they have to go for DEXA scan. But if they are more than 5 years, they have to straight away go for DEXA scan, and we have to see whether they're having osteopenia, osteoporosis, severe osteoporosis. In case of severe osteoporosis, it has to be treated immediately so that we can avoid fractures. Next. 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 Okay. Next. Okay. Next. Okay. So this is one of the important drug which I personally use in my practice, because like anyway, any of like many of our patients will be like having any other diseases like diabetes or obesity associated with that, or most probably they will have a migraine and all. But I before starting hormonal therapy, I personally have used in many patients, and definitely as they claim, they have reduced vasomotor symptoms within a week. Many patients have reported reduced in vasomotor symptoms. So, and it actually has a very, very important role in the treatment of menopause. Before, if a patient is having any contraindications, like we have to rule out, and before starting hormonal therapy, if the patient is not willing for hormonal therapy, you can anyway try this in perimenopause and menopause place. Next. 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 So these are the evidences with the estrogen. They say that it reduces the vaginal dryness, reduces hot flushes, mood swings, and bone pain. I've given for hot flushes and mood swings, and I've seen like tremendous improvement in the symptoms. So they concluded that they have a significant reduction from 10 out of 12 in the Kupperman index symptoms. Definitely, the symptoms release with 7 to 14 days. Next. 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 Yeah, this is how the evidence says that estrogen has bone effect. Okay, improved bone health. Next. Yeah, it actually increases the quality of life. It reduces 9 different symptoms, include like hot flushes, night sweats, parenthesis, nervousness, melancholia, vertigo, fatigue, rheumatic pain, and vaginal dryness of peri postmenopausal women. No adverse events were reported with estrogen 100. It is found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. Next. And they also claim that there is no toxicity even at 2 grams per kg body weight. Next. Okay, next. Thank you. Thank you for the opportunity, Shield Healthcare.
Thank you so much, ma'am, for giving all the detailed information regarding the menopause management. Let me check if we have any queries in the comment section. Okay, ma'am. So there is one question from the delegate. Does estrogen helps in surgical induced menopause?
Yeah, even in surgical induced menopause, if the patient is like having any contraindication for hormonal therapy, it definitely helps in the vasomotor symptoms, which I've used for the surgical menopausal patient only. But definitely, we have to think in terms of long-term health for the surgical menopause patient. If it is done in the age of like very like 35 or 45, we have to assess the patient. If the patient is having any symptoms, and if the patient is not having any contraindications, definitely she will benefit from the high-dose hormonal therapy.
Ma'am, how much cost effective is this therapy for the patients? Do you find that the patients are getting benefit from estrogen
Yeah,
in
definitely
given
patients
duration?
benefited from estrogen, as you already said. Cost effectiveness for the affordable patient, for the affordable
Yes.
patient, the effectiveness is very high. They don't see about the cost, because the effect which they get from this tablet, they sometimes they take for 3 months and they stop, and they are free of symptoms. Okay, and
Okay.
for them it's okay. But for the non-affordable group, definitely the cost is a very big issue for them, that they prefer to stay with the symptoms than going with the cost. It's a little bit high for the
So
non-affordable group.
if it is in comparison with the MHT therapy,
Yeah, with the
then
MST, definitely, like in patients with contraindication, it is the best initially,
okay, ma'am.
at
And
least for
ma'am,
the.
what is your advice on cognitive therapy or the psychological therapy for the women who are coming with this menopause symptoms, who are just new to these symptoms, hot flashes, so they might get anxious. So how do you handle such patients?
Yeah, it is always better, like not only the patients, even anyone. It is always better to educate everyone that, like
Yes.
we educate for everything. It is very important to educate
Mhm.
everyone that men, like they will
Mhm.
not have all these symptoms, but women will have all these symptoms at the age of 35 to 40, and she may not be thinking that what is that stage. She may relate that to any
Mhm.
with the home stress or any other stress, but there is all like happening inside physiological because of the loss of hormone. And they should
Yes.
also it's always better to have a, counseling session with the menopausal practitioner, which is very
Yes.
important, so that they will have more knowledge about menopause, and they'll have more awareness about menopause, and they can
Yes.
make very small changes in their lifestyle, which will help them a lot. And as I already said, they all land up at the cardiology department with the hot flashes, sweating, and the psychiatric
Mhm.
department with the irritability. It is a natural thing, and moreover, a well supported family will help the woman a lot, and she can come out of that very easily. It's a natural happening.
Yes. Thank you,
More
ma'am.
awareness is needed.
So education is needed for
Yeah,
family
for
member
men.
also,
Yeah, all the
and the
family
partner
members. Yeah, they should
of the
understand.
patient.
They should
Yeah.
understand their mother, or they should understand the wife,
Yes. Yes.
what she's undergoing, and it is very important for them.
Thank you, ma'am, for giving all these information on the questions also. So we are glad to have you on our platform, ma'am, and we also thanks delegates for joining today with our session with Dr. Divya ji. And we would like to have more sessions with you, ma'am, on our platform on Shield Connect.
Thank you.
So we can wind up, ma'am. Thank you,
Yeah.
ma'am.